Hello guys. So now in the head and neck chapter, so the next sub chapter that we are going to study is ophthalmology. Okay. So to begin with, we are going with anatomy. So with respect to ophthalmological anatomy, the two main things are only important. Okay. One is the structure or the layers of cornea, and another one is layers of retina. Okay. So we'll see one by one. With respect to layers of cornea, it is going to be epithelium layer on the out, Bowman's layer, stroma, Descemet's layer, and the endothelial membrane. Okay, so these are the five main layers of cornea. For thickness of cornea measurement, we'll be using something known as patchmetry. Okay, please remember this patchmetry. Then one more question that was asked, this was a previous question: what maintains the hydration and transparency of cornea? Okay, so it is the endothelium layer, the last layer. Endothelium layer is what maintains the hydration and transparency of cornea. Okay, then coming on to the layers of retina. So this is how the layer of retina would look like on a pathological slide. And these are the cells that represent it. Okay, so this is what they have been asking. Okay, the layers, to arrange the layers is what the question has been all through the years. Okay, so it is going to be pigment epithelium on the very inner side. See, this is the choroid. Okay, so choroid will be there. Then pigment epithelium, outer segment, inner segments, the outer nuclear layer, outer plexiform layer, then coming to inner nuclear layer, inner plexiform layer. Okay, so it is gonna look almost literally very same, but the names are very different. Okay, then coming to the outermost will be the ganglion layer, then will be the optic fiber layer. Okay, please go through once again, and please revise the arrangement of this order. Okay, so that's it with respect to the basic anatomy of the ophthalmology. Now we'll move on to the specifics of ophthalmology with respect to all the pathologies and disorders that might come with. Okay, so the first thing is we'll discuss about the conjunctival pathology. Conjunctiva, mainly it is conjunctivitis, right? So there are other two pathologies, that is pterygium and puncticula. We'll come back to that. Okay, so conjunctivitis, so it is nothing but inflammation of the eye, right? So it can be because of allergy, bacterial infection, or viral infection. Okay, in allergy, itchy eyes will be there and it will be bilateral. Okay, whereas in bacteria, anyway, infection, right? So it is going to be pus. Okay, pus will be there. Then coming to viral conjunctivitis is what is most common, right? So, the adenovirus is the most common type of viral conjunctivitis. Okay, so please remember that. Then coming to the follicular conjunctivitis, in COVID-19, we used to have something known as follicular conjunctivitis. This is an extra edge point. Okay, then there is something called angular conjunctivitis. These are certain special types of conjunctivitis. Okay, so follicular conjunctivitis, COVID-19, angular conjunctivitis, moraxella. Okay, then coming to acute hemorrhagic conjunctivitis, it is going to be Coxsackie A, where it's discussed in micro, right? The hand, foot, mouth disease, Coxsackie. Okay, enterovirus 70 and Coxsackie will be the hemorrhagic conjunctivitis. Okay, this is what you need to know with respect to conjunctivitis. The treatment, you know, right? Symptomatic treatment we give, and to avoid the associated bacterial infections that might come up with conjunctivitis, we'll be giving ciprofloxacin eye drops and all. Okay, that's it. It's definitely gonna be the conservative supportive treatment that we give. Okay, with respect to conjunctivitis. Then some of the other pathologies with respect to conjunctiva is pterygium, puncticula, and also there is a dermoid cyst. Okay, we'll see what is the what how it presents with. Okay, we'll come back to that. So pterygium, okay, so it is nothing but the fibromuscular ingrowth due to elastic gene degeneration of the subconjunctival tissue. Okay, it will be mostly seen on the nasal side. on the nasal side. If suppose if this is the nose, here one more eye is there, it is going to be on the nasal side most commonly. Okay, so pterygium will be there. Then okay, then there is something called as Stalker's line within the pterygium. Okay, within the pterygium there will be brownish deposition that will be there, so that is called as Stalker's line. Okay, so this is an extra point. Coming to management, it is going to be surgical excision of it. The entire pterygium will be surgically excised, and if needed, graft will be placed. Okay, the graft, the most common graft will be the amniotic membrane. Okay, so this is with respect to pterygium, and please remember there will be 80% reoccurrence that might happen. Okay, the pterygium has a high rate of reoccurrence. Okay, then coming to pingicula, it is almost similar. We'll get confused between pterygium and pingicula, but here it is yellow white. Okay, the thing is yellow white collagen deposition. Okay, so for example, there will be a round body that will be present in the conjunctiva. Okay, so here also it is on the nasal side only. Okay, so that is what I was telling, right? Differential diagnosis will be dermoid. Okay, so almost looks the same. Dermoid, most commonly it would be on the lateral side rather than nasal side. Okay, so that is why the differential diagnosis is very important. Okay, this is all you need to know with respect to conjunctiva. Then moving on further, these are certain of the image based question that they might ask. Please go through all of this. Okay, this thing, episcleritis and scleritis, if you should be knowing the difference. Okay, episcleritis will be only one certain part, but scleritis will be entire eye will be affected. Okay, this is one thing, and this also they have been asking. Okay, the scleromalacia perforans. Okay, this is associated with the rheumatoid arthritis. Okay, an extra articular feature of rheumatoid arthritis. Please remember this. Okay, then moving on further with respect to refractive errors. Okay, refractive errors and all, like it is very difficult to answer these questions. Okay, they have been asking too much in depth with respect to ophthalmology. They think that we are ophthalmological physicians, and that is how they are asking these questions. But if you know, you know. Okay, in that way. So hyperopia, farsightedness, myopia is short-sightedness, astigmatism in old people, right? They wouldn't be able to properly accommodate to the eye, right? So that is how the because of curvature of the cornea is affected. So this is how astigmatism comes in. That is why where we use a spherical lens and all. Okay, so these are the refractive errors, common refractive errors. So now moving on to lens disorders. So the thing is, there is something called as presbyopia, where there is impaired accommodation. Okay, because this is an age-related issue. So there is impaired accommodation which lead because of a lens elasticity loss. Okay, as we start aging, so our lens elasticity will be lost. Okay, so that is when accommodation will be impaired. Okay, this is called as presbyopia. Whereas cataract, we'll discuss more about cataract. I'll come back to that. So now, then there is something called as lens dislocation might happen. Okay, we were discussing, right, in biochemistry, there is homocystinuria and Marfan's disease. Okay, so between these two, there is a difference, Marfan's disease and homocystinuria, where the lens might fan out or fan down. Okay, so in Marfan's, fan meaning fan out, right? So in homocystinuria, the lens used to fan down. Okay, so this is the thing with respect to lens dislocation. So it might also happen with respect to trauma and all. Okay, so that is what, again, Marfan syndrome, homocystinuria. Okay, so these are systemic disease associations. Okay, coming back to cataract. See, cataract is nothing but as we start aging, so there is opacification of lens. Okay, it is painless and bilateral. Okay, so this is the thing. Bilateral meaning it doesn't mean that it should be symmetrically the loss of vision is there. So we know that, right? We have seen many cases in our third years and all. Cataract, we used to go to camps in the internship also, right? So we used to see cataracts and all. So this is the thing. Okay, then the clinical feature is it might result in glare and reduced vision. Basically, that is what the old age people used to come up with, right? And then there will be especially at night the vision loss will be there, and loss of red reflex and all when we elicit this is what we elicit. Okay, loss of red reflex. Then the risk factor is increasing age, basically. Then tobacco smoking, alcohol overuse, and all these things will be the risk factors. Okay, the main thing is diabetes mellitus. Okay, so diabetes mellitus patients will have increased risk of cataract. Okay, then congenital cataract we were discussing in the pediatrics, right? So these are the things. Okay, because of galactosemia. Okay, mainly classical galactosemia will be having this one cataract, and also galactokinase deficiency. In the non-classical galactosemia also this might happen. Okay, then coming to trisomy 13, 18, that is Patau, Edward, and Down syndrome. Okay, all these three can have cataract. Then all the infections we discussed, right, with respect to pediatrics, congenital all the infections will be having ocular symptoms. One main ocular symptom will be cataract with all these things, right? So rubella we had discussed, right? Cataract is one of the major triad. Okay, so these are the things. Okay, so we'll come back to what are the features and how we are gonna manage it. Okay, so cataract, that is what, right? Congenital, we can divide them as congenital and acquired cataract. In acquired cataract, senile cataract is the most common thing. Then there are two other things, that is traumatic and complicated cataract. Okay, we'll come back, we'll finish off this. In traumatic cataract, it is going to be contusion or a blunt trauma or a penetrating injury that might cause this cataract. Okay, so the other thing is complicated cataract, where the systemic diseases are involved, like for example diabetes, all these things, myotonic dystrophy, etc. The other complicated diseases are based on the disease of eye, that is retinitis pigmentosa, and all these things might cause cataract. Okay, then coming to senile cataract, it is going to be two types. Okay, cortical and nuclear. Okay, so cortical type and nuclear type, where it is based on the lens, where exactly the affected part of the lens is. Okay, so if it is going to be around the lens, it is going to be the cortical, whereas the middle one is going to be the nuclear, right? So these are the two types senile cataract might come up with. Then we know, right, immature, mature, and hypermature. Okay, so this is exactly how it's gonna look like when we take a look at the eye. Okay, so immature is gonna look like a halo, whereas mature will be completely whitish pupil will be there. Then hypermature will be yellowish halo. Okay, so this is how it's gonna look like. The other ones are cortical, nuclear cataract. Okay, posterior subcapsular cataract, all these things. Okay, please note down this. And exfoliation. Okay, pseudo exfoliation, please note down this. They have been asking this. Okay, this is how it is gonna look like. Then some of the extra points with respect to cataract is there is something called as after cataract. Okay, so what happens is after cataract, this is a post-op complication with respect to cataract. After we place our artificial lens, right, so there will be posterior capsular opacification. Okay, after placing the artificial lens that we put, right, IOL, okay, intraocular lens, so there will be posterior ossification. Okay, so it might lead to Elshing pearls, soma rings, dense membrane, and thin membranes. Okay, so this is how the opacification might happen. Clinical features will be again same like cataract only. Glare, visual acuity will be reduced, and doesn't improve on pinhole testing. Okay, so we will think that probably and some visual acuity difference is there, but probably some refractive error, but no, even on pinhole testing it wouldn't improve. So that is when we'll have to do the surgery again. So this is what after cataract means. Okay. Then these are certain specific features that would look like in the cataract. These are the certain features with specific diseases. So in Wilson's disease, that is copper deposition, right, in the Descemet's membrane. So sunflower cataract will be there. In a blunt trauma, so it is going to be rosette shaped cataract. Okay, flower shaped cataract will be there. Then coming to diabetes mellitus, sunflower cataract, please note all these things down. Okay. Then myotonic dystrophy, it is going to be Christmas tree pattern. Okay, so Christmas tree pattern meaning the cataract will be something like this. Okay, so eye pupil, so cataract will be Christmas tree pattern here, whereas snowflake cataract will be in diabetes mellitus. Okay, that's it. Then some of the infections that might happen post cataract surgery is, if it is less than 6 weeks the eye is having an infection, then it is going to be streptococcus epidermidis. Okay, staphylococcus epidermidis, whereas it causes endophthalmitis. Okay, then if it is more than 6 weeks, it is going to be pseudomonas acnes. Okay, so that's it. So this is the main thing. Okay, so please remember this table, it will be easier for you. Okay, that's it with respect to cataract. Now we'll move on to the very most important topic, that is glaucoma. So what exactly is glaucoma? So what happens is, so there is aqueous humor, right? So aqueous humor will be produced between lens and the cornea, right? This aqueous humor has to be flowing, right? It has to be drained, and all the production can't stay within the aqueous chamber itself. Okay, it has to flow, but if there is a flow hindrance, so it is going to cause glaucoma. Okay, so there might be increased pressure, and there might be optic neuropathy that might happen because of this increased pressure. Okay, so that is what exactly the glaucoma means. Okay, it doesn't mean that there is increased intraocular pressure. Okay, because this is the anterior chamber that is involved. Okay, so always it doesn't mean that there is increased ocular pressure. Okay, we know that there is fluid and it is increasing pressure, but it doesn't mean always this is the thing that is happening. It might accompany it, but it is not always the thing that is there. Okay, then the etiologies might be primary and secondary. Okay, so primary because of some trabecular meshwork thing only will be affected, whereas secondary to other causes. For example, some infection might have happened, uveitis must be there. So these can cause the blockage of the trabecular meshwork and cause the glaucoma. Okay, so these are the things with respect to glaucoma. Now let us see the specific types. Okay, so we know that, right? Angle closure glaucoma and open angle glaucoma. Okay, angle closure glaucoma and open angle glaucoma, what does that mean? So basically in open angle glaucoma, there is see, what happens is, between the lens and the cornea there is an angle. Okay, so if this two angle is closed, like if the cornea is very close to the lens, so what happens to the, to the iris? So what happens is, here the angle will be very closed, right? Open closed, right? So what happens is, this is what angle closure glaucoma means. Okay, so suppose now if there is the angle is open, but there is trabecular meshwork that has been affected. Okay, so there has been block in the drainage. Trabecular meshwork is nothing but a drain. Okay, so this is a mesh. We are all be having drains in our home, right, near the sink and all. So this is how the trabecular meshwork looks like. Looks like a mesh. Okay, suppose if there is blockage of this mesh, what happens is there won't be the flow of aqueous humor, right? So that is how the glaucoma would happen. Okay, so this is the main pathogenesis between these two things, that is open angle glaucoma and angle closure glaucoma. It is because of the angle that is closed with respect to angle closure glaucoma. Okay, so let us see one by one. So open angle glaucoma, here that is what the angle chamber will be opened. Then there is the increased resistance through the trabecular meshwork. Okay, the main thing is in uveitis and diabetic mellitus patient and all, this usually occurs. Okay, this is usually asymptomatic. Okay, so this is typically asymptomatic and discovered incidentally. Okay, if suppose we are testing for some other thing, for example visual acuity and all, so this is diagnosed incidentally. Okay, then coming to angle closure glaucoma, this is the thing that is very important, because here it is very painful. Okay, so the pathogenesis I told you, right? Then what happens is there is increased pressure when there is an acute case. Okay, there is something called as acute angle closure glaucoma, where there is increased intraocular pressure, which might lead to severe eye pain and conjunctival erythema. Okay, we might think that it is some conjunctival pathology that we are dealing with, but no, it will be angle closure glaucoma, because the pain will be severe as compared to conjunctivitis. Okay, conjunctivitis, there will be severe irritation rather than pain, but here there will be increased pain, amount of pain. Okay, the other associated features will be, there will be sudden loss of vision. So the sudden loss is main thing. Then the other ones are halos around the lights. Then headache will be there. Mid and fixed dilated pupil will be there. Nausea, vomiting. These are the associated symptoms. Okay. So then what is the management? It should be managed immediately, because or else it might lead to blindness. Okay, so that is why we'll be treating the acute angle closure glaucoma in a emergency manner. Okay, so how do we treat it is with the avoiding the mydriatics. See, if we give mydriatics, it will open, what we think is it will open the eye and it will reduce the angle closure glaucoma. No, see, angle is getting closed. Okay, so if I start opening the eye, if I start dilating, the angle will be much more closed, right, and it might worsen. So that is why we should use myotics. Okay, myotic agents is what we are supposed to use. Okay, the other way of management will be express implants. Okay, there is something called as express implants. Please remember this. Okay, this is like gourmet. Okay, so like gourmet we used to introduce in our ENT, right, in myringotomy. So this is exactly the same way. It is an implant that we place there, and it will drain the aqueous humor. Okay, there is something called Oakes triad. Please go see an image of Oakes triad. This might be an image based thing. Okay, so Oakes triad, what is the investigation that we do is tonometry. That is what, right? So tonometry will measure the intraocular pressure. So that is how we can know what type of pressure and what exactly is happening in the eye. Okay, so tonometry can be done. Okay, then the other drugs and all, you should be knowing all the carboprost, all these things we use, right, latanoprost and all. So this is what with respect to glaucoma is. Then there is something called 100-day glaucoma. Okay, so 100-day glaucoma, what happens is, in central retinal vein occlusion, we'll come back to the central retinal vein occlusion. What happens is, this might lead to a complication where it might lead to glaucoma after 3 months. So that is why the name 100-day glaucoma. Okay, then contrary to glaucoma, there is something known as hypotony. Okay, that was hypertony, right? The tonicity, the pressure was increased. Here in hypotony, there is excessive reduced IOP. Okay, so intraocular pressure is reduced. Okay, this might lead to maculopathies and vision loss might happen. Okay, the main etiology is trauma. Okay, there will be in penetrating trauma, which might lead to leak out of all the aqueous humor and vitreous humor. Okay, so this is what the hypotony means. Okay, then coming to glaucoma treatments, I was telling, right, you should remember all the latanoprost, bimetoprost and all these things. Okay, so this is with respect to uh, how we will be treating the drainage. Okay, us chloral outflow is how we do the drainage of. Okay, and in meshwork I was explaining about the meshwork, right? So this is canal of Schelm. Okay, so this is the canal through which the aqueous humor will pass through. Okay, if that is affected, that is when we'll get the open angle glaucoma. Okay, open angle glaucoma is that thing. Okay, so to drain this we are gonna use carbachol and pilocarpine. Okay, so it increases the drainage of the fluid. Okay, then the other thing is the amitriptyline, the antipsychotic should be avoided in angle closure glaucoma patients. Okay, this is an extra edge point. Please remember this. Okay. We discussed about the penetrating injury glaucoma, right? So there is something called as angle recession glaucoma, which happens because of blunt trauma. Okay, penetrating trauma. I told you, right? It was causing a hypotony. Okay, but there is something called as angle recession glaucoma, which happens because of a blunt trauma. Okay, what happens is after blunt trauma, there might be increase in fluid secretion, or there might be block of the trabecular meshwork or canal of Schelm. Okay, so this might lead to angle recession glaucoma. Okay, with the preference of drugs in the management of glaucoma, pilocarpine is preferred over atropine. Okay, so please remember this. Atropine worsens the angle closure glaucoma. Okay, so pilocarpine is preferred over atropine. Okay, that is all and everything you need to know with respect to glaucoma. Okay, cataract is done, glaucoma is done. Okay, only the important points are very important here with respect to ophthalmology. Okay, then coming to all the infections of eye, we'll discuss one by one. Starting from conjunctivitis. So we discussed, right, angular closure glaucoma, moraxella, viral conjunctivitis, adenovirus, and H influenza. Acute hemorrhagic is enterovirus and Coxsackie. We discussed, right, hand, foot, mouth disease might lead to conjunctivitis and all. Okay, this is the thing. And in kids, in Kawasaki disease and all, this might happen. Okay, it is not a criteria to be happen in Kawasaki disease. It might happen in Kawasaki disease. Okay, that is the thing with respect to conjunctiva. Coming to uveitis. What does uvea actually mean? Uvea means the iris, ciliary body, and the choroid. Okay, all the three layers, if they are involved, it means uveitis, right? So that is what holds the lens. Okay, so near the lens, whatever is there. So if this is a lens holder, okay, so iris is there. Okay, ciliary body which holds the lens, and just below it, this is the choroid, right? So of all the three layers is affected, then it is gonna be uveitis. Okay, there are four types of uveitis: anterior uveitis, intermediate uveitis, and posterior uveitis, and pan uveitis. Okay, so here in anterior uveitis, this is the thing: iris and ciliary body will be affected, whereas intermediate will be pars plana of the ciliary body, and the vitreous will be affected. Whereas in posterior uveitis, so it is the anterior chamber that we were discussing with respect to anterior uveitis, whereas the posterior chamber, if it is getting affected, then it is going to be posterior uveitis. Then pan uveitis, meaning the entire the uveitis will be affected. Here the entire eye might be getting affected. Okay, so this is the thing with respect to uveitis. So features are all same: inflammatory features, eye pain, redness, all these things will be there. Okay, there might be hypopyon in anterior uveitis. You know hypopyon, right? For example, if this is the cornea, there might be some white. Okay, so I'm drawing it in black, so please remember this is a white. Okay, so let me draw cornea black. Okay, so black cornea is there. So suddenly there will be some white deposition just below the cornea. Okay, this is called as hypopyon. Okay, so we can see in the anterior uveitis. Okay, so the mainstay of treatment will be treating the underlying cause. So whatever would have happened, would have led to the uveitis, will treat them first, and then we'll control the inflammation through corticosteroids. Okay, steroids can be topical steroids and oral steroids. Then coming to immunosuppressive agents and all, we mostly won't use, and we also can use mydriatics. Okay, so mydriatics, because there might be some pupillary issues and all, because pupil will be very small. Okay, meiosis might be having, so the happening, so that is why we use mydriatics. Okay, then there is something called sympathetic panuveitis, where the other eye also will be affected. Okay, so the normal eye also might be affected in panuveitis. Please remember that. Okay. So this is what I was telling about hypopyon, anterior uveitis. Here the hypopyon will be there. Okay, so in that way, then snowball appearance in the intermediate uveitis. Posterior uveitis, I told you, right? The posterior chamber will be affected. That is how we'll see the choroid and retinal lesions. Okay, mutton fat precipitates might be there. Okay, so these are certain of the things that you should be aware of. Okay, then coming to some of the important images with respect to this immunofluorescence that they give is, if you see this thunder-like appearance, so it is going to be viral keratitis. Okay, so please remember that. Okay, then coming to orbital cellulitis, in orbital cellulitis there are two types. Okay, so that is preseptal and postseptal orbital cellulitis. Okay, so the most common organism that is involved here is rhizopus. Okay, so please remember this rhizopus. Okay, it is a fungus we discussed in mycology, right? So this is the thing with respect to orbital cellulitis. Then there is trachoma. So there are four stages. We used to learn this in ophthalmology, right, for our exams. So incipient stage, established stage, cicatrization, and Herbert Spitz. Okay. So Herbert Spitz is very pathognomic to trachoma. You know that, right? So there is cornea, and around that Herbert Spitz will be there. Okay, so this is the thing with respect to trachoma. Okay, there is something called safe strategy that we follow to avoid trachoma. It is surgery, antibiotic, and facial hygiene, environmental cleanliness, and all with respect to maintaining the eye hygiene to avoid trachoma is what we do. Okay. Then coming to ophthalmia neonatal term, we discussed, right? Chlamydia, if it is less than 5 days. If it is more than 5 days, it is going to be gonorrhea. Okay, so more than 5 days is what is dangerous. And that is with respect to gonorrhea, ophthalmia neonatal term. We discussed in neonatology. Okay, so that is the thing with respect to all the infections of the eye. Okay, so now we'll move on to the specifics of retinal disorders, and then we'll come back to the all the optic nerve related disorders. Okay, so that's it with respect to ophthalmic disorders. Okay, now one by one let's see the retinal disorders. Okay, so there is something called as cystoid macular edema. See, all these things, retinal disorders, when we see fundoscopy, there will be some specific finding. So for that specific finding, let us see what exactly is happening. Okay, so in cystoid macular edema, there is fluid between the outer plexiform layer and the inner nuclear layer. So we discussed, right, the layers of retina here, between the outer plexiform layer and the inner nuclear layer. Okay, so between here there is a pathology. Okay, this is called as cystoid macular edema, where the fluid starts filling over there. Okay, so that is known as cystoid macular edema. Okay, so when we see a fundoscopy, so fundoscopy is what we do to visualize retina, right? So when we do that, there will be in fluorescence, there will be ongoing flower petal pattern. Okay, flower petal pattern will be there. Okay, when we do fluorescence angiography, so flower petal pattern will be there. Please remember this specific finding. Flower petal pattern will be there with respect to cystoid macular edema. Then coming to age related macular degeneration, scotoma will be there. That is loss of certain eye fields will be there, central eye field and all. So there are two types, dry type and wet type. Okay, so dry is gradual loss of vision, whereas wet type is rapid loss of vision. Okay, so here drusen can be seen. Okay, so what does drusen mean? So let me show you the image. Okay, so this is what a drusen would look like. Okay, so these dots are there, right? So this is what a drusen would look like. This is the specific sign of age-related macular edema. Okay, so Drusen sign. Okay, so this is the thing. Okay, then coming back to diabetic retinopathy. So these are the things that is important, right? Diabetic retinopathy, hypertensive retinopathy, that we do in everyday clinics, right? So that is how we start treating the patient also, right? So in diabetic retinopathy, please remember these things. Okay, non-proliferative, proliferative retinopathies. Okay, in non-proliferative, there is microaneurysm and there is no neovascularization. Okay, this proliferation is based on whether the new blood vessels are being formed or not, because the old blood vessels are being blocked. Okay, blocked by increased amount of glucose. Okay, so increased glucose start depositing in the retinal vessels and these are getting blocked. That is why there is a new vascularization. If the new vascularization is happening, then it means it is complicated, right? So that is why in proliferative diabetic retinopathy these things will be there. Okay, new vascularization. Okay, due to hypoxia, basically it is getting, the other old ones are getting blocked, so that is why the new genesis is happening. Okay, there is an increased risk of retinal detachment. Okay, there are types of retinal detachment. So tractional retinal detachment is what is important with respect to diabetic retinopathy. Okay, so that is why in everyone at the 45th year of birthday we'll do fundus examination. Okay, 45th year birthday, they might ask you this question, at which birthday we'll tell them to get a diabetic retinopathy. It doesn't matter if they are having diabetes or not. For everyone, it is a must. Okay, because we can easily we do the prognosis, what the disease progression has been. Okay, so here the specific point is cotton wool spots. Okay, cotton wool spots would look something like this. Okay, so cotton wool spots will be there. Okay, these spots are cotton wool spots. Okay, so in this thing. Okay, so this is how diabetic retinopathy would look like. Then coming to hypertensive retinopathy, we used to do in emergency, right? So papilledema and all we used to see, right? So here also the same thing, similar to diabetic retinopathy, cotton wool spots will be there. Okay, cotton wool spots will be there with respect to diabetic retinopathy. This is because of chronic hypertension. There will be microaneurysms, just like diabetic retinopathy only. Here it will be the microaneurysms that are there. There it was glucose and fats that was getting deposited. Here it is the aneurysms that is causing the hypoxia. Okay, so there might be hemorrhage also, right? Because the aneurysm might rupture and cause hemorrhage. Okay, so this is what the hypertensive retinopathy would happen. So here also that is what the uh, flame shaped and all these cotton wool spots will be there. Okay, so here also this is with respect to hypertensive retinopathy. Coming to retinal artery occlusion, it is mainly because of emboli. Okay, so some emboli would have block the retinal artery. Okay, so again there is something called a retinal vein occlusion. We'll come back to that. In retinal artery occlusion it is emboli. Okay, please remember it is emboli, whereas in retinal vein occlusion it is going to be thrombosis. Then and there itself the artery, I mean the vein is getting blocked. But here in retinal artery occlusion, it is from somewhere it has traveled. Okay, for example, if in atrial fibrillation or something like that and chronic hypertensives, okay, so this might happen. Okay, there will be reduced retinal circulation which leads to pale retina. Okay, so that is why the fovea will be normal. Okay, because it has a different circulation than and coming from the ophthalmic artery. Okay, so that is why the foveal circulation will be normal. That is why it looks like a cherry red. Okay, see around the uh, in retinal artery occlusion, please see this image. Around the fovea is what has become pale. So that is why, so with respect to fovea, it is becoming cherry red, right? Cherry red is there. Okay, so this is how the pathogenesis of retinal artery occlusion would look like. Okay, so this is the fundoscopy. Then coming to retinal vein, I told you, right, it is the thrombosis that is happening. So it is because of retinal hemorrhage or venous engorgement. and all these things. Okay, so 100-day glaucoma can also complicate to I may can also be the complication. I told you, right? Retinal vein occlusion might lead to 100-day glaucoma. It is a complication. Okay, so how would the fundoscopy look like? It looks like a thunder appearance. Okay, thunder. See, thunder after the rain. Okay, so this is how the fundoscopy would look like. Okay, then coming to retinal detachment, I told you, right, there are many types: tractional, regmatogenous, non-regmatogenous, and all these things. Okay, so what happens is, it is the sensory layer that is getting separated from the pigment epithelium. We discussed in the layers of retina, right? So there is something called sensory layer which will be detached from the pigment epithelium. Please remember this line. Okay, so they'll ask you, okay, which layer is getting affected. Sensory layer and the pigment layer is getting affected. Okay, so there are types, right? Regmatogenous and non-regmatogenous. So in regmatogenous, there will be a small tear, okay, in the retina, which where the fluid might surge. Okay, there will be a small tear. Okay, so from there the fluid might surge. Whereas in non-regmatogenous, we discussed, right, with respect to diabetic retinopathy, here there is a tractional and exudative. Okay, so there might be traction because of some trauma or some diabetes and all. So there might be traction and adhesion which might lead to pulling the retina out, okay, between these two layers. So that is what tractional means. And if there is some infection and all, that might lead to exudative. Okay, so exudation might go in between these layer and cause this. Okay, this is what retinal detachment types are. Okay, so how would it look like? It looks like a wrinkling of detachment of retina, right? So because it was adhered to the base layer, but if it is pulled out, it looks like a bed sheet that has been pulled out, right? So a pulled out bed sheet, after we get up from our beds, this is how the bedspread would look like, right? So this is what is called as retinal detachment, or the fundoscopy of retinal detachment would look like. Okay, then retinitis pigmentosa is very important and favorite examiner's question. This is exactly the spicules. Okay, the black spicules. If you see the retina itself, when you see retina with all these black spicules, okay, and all these thing is there, right? Please go for retinitis pigmentosa. Okay, it is basically degeneration of photoreceptors. Okay, that's it. That's what bony spicules and all will be there with respect to fundoscopy. Then papilledema, we used to do it for hypertensive patient, and if there is a trauma in the head, right? Head trauma is there. Suppose we are trying to elicit if there is intracranial pressure increase in this patient because of cerebral edema and all these things, right? So that is why we used to go for papilledema. Okay, so here you are seeing, what we are seeing is optic disc edema. Okay, so that is what elevated optic disc with the blurred margins will be there. Okay, here see, compared to other images, see this optic disc. Okay, so it has been enlarged, right? So this is the elevation of optic disc. So this is what the papilledema would look like. Then there is please remember, this is extra edge point with respect to chloroquine toxicity. It might lead to bullseye sign. Okay, bullseye sign. Okay, so bullseye meaning bullseye. Okay, so bullseye sign will be there. Then with respect to toxoplasmosis, punched out lesions might be there. Chorioretinitis, we saw, right? So with respect to toxoplasmosis, there might be chorioretinitis, which might lead to punched out lesions. Okay, this is all with and everything with respect to the retinal disorders. Okay, so now the last part with respect to all the movement disorders and the pupillary reflexes we'll see. Okay, so then we'll be done with ophthalmology. Okay, so the main thing with respect to the movements of eye will be, remember, LR6 SO4 R3. What does that mean? LR6 meaning the lateral rectus will be supplied by the sixth cranial nerve. I told you, right, three cranial nerves that passed through superior orbital fissure will be supplying the muscles of the eye. Okay, so these are the three nerves which will supply the muscles of the eye. That is LR6, the lateral rectus will be supplied by the sixth cranial nerve, whereas superior oblique muscle will be supplied by the fourth cranial nerve, whereas all the other muscles will be supplied by the third cranial nerve. Okay, so oculomotor nerve, basically third cranial nerve. So this is the thing. So if you remember LR6, SO4 and R3, you will be able to solve all the questions, because they might ask you which is affected, and you can see, okay, lateral rectus, the patient is not able to abduct, meaning abduct the left eye, meaning okay, LR6 is lateral rectus is what pulls the eye to the lateral side, so it is affected, meaning cranial nerve 6 is affected in that way. Okay, this is how you correlate with the eye movements. Okay, then coming to squints. Okay, squint strabismus is what we call it, right? So strabismus, there is esotropia meaning the eye would look towards the nasal side, whereas exotropia, outside. So exo is outside, right? So it would look outside. Okay, then hypertrophia is looking above, then hypotropia when it is looking below. Okay, so this is the main thing where they'll ask you what is it. Okay, that's it. So this is how you identify it. So association would be exotropia is associated with myopia. Okay, so short sightedness most of us will be having, right? So myopia is associated with exotropia, whereas esotropia is associated with hypermetropia. Okay, please remember this. Okay, then there is something called as convergent squint, which is most common in refractive errors. Okay, convergent squint is most common in refractive errors. All these myopia, hypermetropia basically will lead to convergent squint. Okay, so one more thing I want you guys to remember is, with respect to squint surgery, basically how do we manage this? So in some of the mild cases and all, we'll leave as such. If the patients want some beautification and all, that is when we go for surgery. Okay, so this wouldn't affect any everyday life. If it only affects some visual acuity, so that is when the patient might want it and will go for surgery. How do we diagnose this is based on cover test and uncover test. We'll cover the eye, one eye, and we'll try to elicit, okay, from to which particular side the eye is getting moved. Okay, so if we open the both eye, then we wouldn't be able to appreciate that much of strabismus. We would be definitely knowing just by looking the face itself strabismus is there. To elicit more, we should cover and uncover the eye, then we will be able to elicit it. Please remember this test. They might ask you a video based question based on this. Okay, so now coming to management, so please be aware, during squint surgery there might be a oculocardiac reflex that might happen. Okay, and patient might die. Okay, so there is something called as oculocardiac reflex, which might lead to an emergency situation. Okay, so this is all and everything with respect to movements of eye and all the muscles that is involved here. Okay, then coming to the pupillary reflexes. Okay, so this is how the light reflex will be carried from eye. Okay, so from retina, it is the optic nerve that is carrying the signal. Then it will reaches the optic chiasma, optic tract. You know that, right? Eye is there. It will from here. It is carried by optic nerve, optic chiasma. It has reached chiasma, meaning this to congruation. Okay, so optic chiasma it has reached, then it is traveling towards the midbrain. Here the Edinger-Westphal nucleus is there. Then what happens is, from Edinger-Westphal nucleus there comes a nerve called oculomotor nerve, which carries the signals to the ciliary ganglion. Okay, here the ciliary ganglions will be there. From there it will supply the sphincter pupillae muscles, and pupils might constrict. Okay, this is with respect to constriction of the pupil. Okay, whereas for us the dilation, it is quite different. Okay, dilation is different with respect to how the pupil would look like. Okay, so with respect to dilation, it is the hypothalamus that is involved here. Okay, so hypothalamus, it is not based on dilation, is not based on the light reflex that is happening. It is based on the hypothalamus information that is being come. Okay, so it mainly acts on the long ciliary nerves. Okay, there it was short ciliary nerves, whereas it is going to be long ciliary nerves with respect to the mydriasis. Okay, so it causes the dilation of the pupil through dilator pupillary muscles. Okay, so this is how the meiosis and mydriasis happens. Okay, So if for example optic nerve is affected, optic nerve is what carries the signal towards the Edinger Westphal nucleus, right? So when optic nerve is defected, there might be pupillary reflex issues, whereas even the oculomotor nerve is defect, then also there might be the pupillary reflex issues. Okay, so we'll see that. Then coming to some of the important features with respect to certain diseases is in pupillary reflex is Marcus Gunn pupil, Argyll Robertson pupil, and Hutchinson pupil. Okay, so this we had already discussed in that particular chapters. I told you, right? Optic neuritis is one of the best feature we can elicit in MS. That is. Multiple sclerosis we discussed in neurology, right? So in multiple sclerosis, optic neuritis will be there. So the problem is with the optic nerve. Okay, so that is what afferent pathway is affected. Okay, so in Marcus Gunn pupil, afferent pathway, that is that meaning, so here the signal itself is not being carried. That is what I told you, right? Each region would be affected. Okay, so it leads to a different pathologies. So Marcus Gunn pupil meaning the afferent pathway is affected and there won't be pupillary reflex. Okay, reflex won't be carried at all in that particular eye that is affected. Then coming to Argyll Robertson pupil, this is neurosyphilis. Okay, neurosyphilis, a complicated case of syphilis. What happens is here in the name itself I had told you, right? Argyll Robertson pupil meaning accommodation reflex is preserved. Okay, ARP, right? ARP, Argyll Robertson pupil meaning accommodation reflex is present. Okay, whereas the pupillary, the light reflex is affected. Okay, here the accommodation reflex is present, whereas the pupillary light reflex is affected. Okay, so what happens is the problem is in the midbrain light reflex center. Which is the light reflex center? It is uh, the Edinger Westphal nucleus that is affected. So that is the thing with respect to neurosyphilis. Then coming to Hutchinson's, it is on the problem way out. So oculomotor nerve is what was carrying the efferent pathway, right? So if this is affected, it might lead to dilated and non-reactive pupil. Okay, so because it was carrying the parasympathetic signal, if it is not there, what happens? So it might go to dilation, sympathetic. There is no parasympathetic inhibition at all. So that is why there might be completely sympathetic and it will always be dilated. So this is what Hutchinson pupil would look like. Okay, mainly because of uncal herniation. Uncal herniation happens in the brain with respect to cerebrum herniation. Okay, uncal herniation is nothing but, so there is oculomotor nerve that is going, and in the cerebellum, so there might be herniation and causing damage to the oculomotor nerve. Okay, so this is what is with respect to Hutchinson pupil. Okay, then there are some of the causes of small pupil and dilated pupil. Please go through that. And then the examiner's favorite. This has been the visual fields and how it is getting affected. Okay, see, this is how the signals are being passed. Okay, on from the lateral side, from whatever the signal comes in goes to the same side only. Okay, so in here also it is going to be same only, but from the medial side, okay, so from the medial side whatever the signal is coming, no, it is traveling to the opposite side. Okay, opposite side of the brain. Here also from the medial side whatever the signal is coming, it is going to go to the opposite side. So remember this and your life will be easier with this. Now whatever I'm seeing from the lateral side, no, it will fall onto the medial side of the eye. Please remember that whatever I'm seeing from the lateral side, whatever now I'm seeing, right? So whatever I'm seeing on the lateral side coming is falling on the medial part of the eye. Okay, medial is carrying the signal to the opposite eye, right? Then in the same way, whatever I'm seeing on the nasal side, on my nasal side, is falling, all the light is falling on the lateral part of the eye. That's it. Okay, so the lateral is carrying the signal to the same side, right? So this is how. So if this question comes up, please in your brain itself you start drawing this particular diagram and it will be easier. It will make your life easier. Okay, so For example, the question will be on the nasal side, bilateral by nasal side, the eye is getting affected. Where exactly the pathological lesion would be? So where exactly the lesion would be? From nasal side, I'm not able to see meaning. On the lateral nerve, somewhere here or here or here, the damage might be there, right? So that is how. So this is exactly the diagram that they are asking about. Okay. So, for example, bitemporal loss is there. See, bitemporal meaning, bitemporal meaning I am not able to see on the lateral side of the eye, right? So, on the both the lateral side, I am not able to see. From lateral side meaning, where is it falling? On the medial side, right? The eye reflex is falling on the medial side of both the eye. So, where will the medial side come? Okay, so it will go to the other eyes. So where might be the damage be? It is in the optic chiasma. So that is how we can diagnose the thing. Okay, so with other diseases also it is the same thing only. Okay, monocular meaning here exactly in the this part of the eye it is lost, the lesion is there in that way. Okay. And remember, during visual acuity testing, angle subtended is 5 minutes. Okay, so this was a previous year question. Okay, so angle subtended in the Snell's chart is 5 minutes. Okay, so this is the thing I want you guys to learn. Okay, that's it with respect to all the visual acuity, pupillary reflex, and all. One of the most important topics that has been asked again and again is with respect to the internuclear ophthalmoplegia, or with respect to MLF. Okay, that is the medial longitudinal fasciculus. Okay, so let us see what is it. Okay, when I the thing is, when I try to look left side, okay, these are eye. Okay, so now I'm trying to look at this is the patient's eye. Okay, so patient's eye meaning this will be the right side and this will be the left side. So for example, let us take, I'm looking to the right side. So when I try to look at the right side, so both the left eye and right eye both will move, right? It is not only the right eye that moves, it is also the left eye that moves, right? So this, how does this happen? So here the lateral rectus is working, but here it is the medial rectus is working, right? So how does the brain know, or how does the eye know it is the medial rectus that is to be moved? So that is where the MLF comes in. Okay, so medial longitudinal fasciculus is what decides what sends the signal and coordinates the eye. Okay, so if this is getting affected, so that is where there is a lesion in MLF, that is where the problem occurs. Okay, so let us see one by one. So that is what, right? So it was supposed to carried by a third nerve and sixth cranial nerve. So MLF is in the middle, in the medulla. If it is getting affected, so there might be issue with the movement of the eye. Okay, so there won't be the coordination of movement of eye will be lost. So the two main syndromes are internuclear ophthalmoplegia and 1.5 syndrome. Okay, so what is the difference? Let us see. Okay, if for example I'm looking at the right side, and I'm not able to move the left eye, here I can get the abduction, but here the nystagmus will be there because the eye wouldn't be able to move to whichever the side. Okay, so that is what the internuclear ophthalmoplegia means. Okay, so here the affected side will have the nystagmus. Okay, please remember in INO affected side will have the nystagmus. Okay, whereas there is something called as 1.5 syndrome. Okay, here, so what happens here with respect to 1.5 syndrome is, suppose here I'm trying to look at the right side. Suppose as I told you, if I'm looking to the right eye, so both the affected eye and the right eye wouldn't be able to adapt. Okay, so let me be clear with you. Please forget the with respect to INO I was telling, right? Please forget everything. Okay, so this is a fresh start with respect to the 1.5 syndrome. I'll clear your doubt with respect how you differentiate INO with respect to the 1.5 syndrome. Okay, in INO, that is internuclear ophthalmoplegia, I told you, right, all the pathogenesis and all, you know, the MLF is affected on the that particular side. For example, right eye. Okay, so forget this entire diagram. I'll clear your doubt with respect to how you can differentiate between them. Okay, so this is the right eye. So the right eye is trying to look to the right. Okay, and the left eye wouldn't be able to move its eye to the right side. Okay, so this is what INO means. But with respect to 1.5 syndrome, what happens is, suppose the left eye is affected, left eye is now affected, neither eye can look to the left. Okay, so here in INO, right eye could move to the left, but here in 1.5 syndrome, the right eye wouldn't be able to move to the left. The affected eye is left eye, but still this wouldn't be able to move to the left or right. Okay, so the unaffected side also wouldn't be able to move to the left side. Okay, so this is the difference between INO and OHS. Okay, 1.5 syndrome and INO. Okay, so this is a little confusing. Just go to this diagram and study once again, and you will be able to do it. Okay, so this is by you yourself trying to elicit the signs, you will be able to solve it. Okay, if unaffected side is also affected, then it is gonna be OHS. Okay, but if it is only the affected side that is having the nystagmus, okay, so then it is going to be INO. Okay, so that is the thing with respect to this particular topic. Okay, then some of the miscellaneous stuff I want to tell you is pre-verbal child visual acuity. So child wouldn't be able to tell, right, whether I am able to see or not see. So that is why that is where we go for optokinetic nystagmus testing. Okay, if there is any nystagmus when we show that particular chart or something, that is when we see that tells that okay, the baby is able to see it. Okay, then there is a Teller's visual acuity chart that we use and try to elicit whether the baby is able to see or not. Okay, then retinoblastoma, this is the cancer of orbit. So it arises from the retinal cells. Okay, so we know that, right, RB1 gene is what is involved here. Okay, so the most important point is the histology, that is Flexner Weinstein Rosette. Okay, so Flexner Weinstein Rosette is the histology of retinoblastoma gene. So this is the most important thing. Okay, that's it. Okay, differential diagnosis rhabdomyosarcoma. So please do not confuse rhabdomyosarcoma with this. Okay, the mainstay of treatment is chemotherapy and enucleation. So chemotherapy is vincristine, carboplastin, etoposide. Okay, so this is the thing. Okay, when we see the pupil, it is going to look like just like cataract only, but in the pupillary reflex is what it looks like. Okay, when we do the pupillary reflex, so white pupillary reflex is what we can see, just like cataract only, it will look it will be there. Okay, the most commonly in children only will get to see retinoblastoma. Okay, so please remember that. Then optical coherence tomography is used to visualize the layers of retina. Okay, this is the previous year question. Okay, optical OCT is what we used for visualizing all the layers of retina. And in next point is the in cornea surgeries, right, for example keratoplasty is there, cornea surgeries or some LASIK surgeries and all, if we are doing, so we'll be using something known as McCarry-Kaufman's suturing. Okay, so here the nylon is used. Okay, nylon is what is used as suture material. Okay, McCarry-Kaufman suturing, please remember that. Then boxers should avoid radial keratotomy. Okay, radial keratotomy is not done in boxers. Okay, then retinal detachment we discussed, right, tractional at the last point, tractional will be diabetic retinopathy, whereas rhegmatogenous is in myopia and refractive errors. Okay, so please remember these 2 points. Okay, that is all and everything you need to know with respect to ophthalmology. Okay, this is all you need. Okay, more than this, anything if they ask, no, it will be some extra points, and those are idiots that they are asking. Okay, so they think that we are ophthalmologists, and they do not think that we are going to give an ophthalmology exam. Okay, so more than this, if anything if they are gonna ask, think that they are idiots. Okay, so please leave that question. Okay, that's it. Thank you.